All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. This is a third talk for today. Welcome very much, and thank you very much for being here. Carolyn is first. DDS is hi. Sumit, hello back to you. How are you doing, doctor? We have Mercy Turner. Hello back to you. Jenna, hello back to you. Lorene Kirby, hello from Algebra Bean. Wow, that's a very nice name. Eligi, hello back to you as well. Violet Meadow, good evening. Same back to you as well. Rubies are red here and still annoyed. So what happened, Rubies? DDS. And then there are lots of people. Arun, how are you? Doug, how are you? Denise, how are you? Carolyn, how are you? Where is Margaret today? Treb, hello from Detroit. Hello. So Arun, I see your question. Let's see. Arun says, Arun Mehta question. So children should also be on ivermectin prophylaxis. So what is the dose? Arun Mehta question. Can't pharma make ACE2 receptor only be by recombinant technology and give to children? So number one, so two questions here. Very good questions. So there have been pharmaceutical products that are in process, and I believe they would soon be in trial or already in trial, which are fake ACE2 receptors that you inject in the person and they go and mop up the SARS-CoV-2. So that product is already being made. And I would talk about Dr. Alexandros from Greece, that he was the one in very early time that he had given that idea as well here in a comment to say, hey, why shouldn't we do that? So very good that people continue to think about that process. So that is in progress. Your first question about the children and ivermectin, yes, children and ivermectin, the only contraindication is children that are smaller than 2 years of age or lesser than 15 kilogram of weight cannot have ivermectin or should not have ivermectin. Children bigger than that can have it, and I would use FLCCC's ivermectin protocol. The only change I will make is that instead of 0.2 milligram per kilogram, I would bring it down to 0.15 milligram per kilogram, and then dose 1, dose 2, 1 day, 3 day, and then bi-weekly. So generally, children are very much protected, but if some children have comorbidities or there is a risk, then this, I think, is fair to do. Dr. Griff Bean says, hey, Dr. B, from a mechanism perspective, what's your thought on why peds don't seem to get hit as hard as adults? In theory, their immune system can't be as robust as an adult. So very good question. And I have actually done a very detailed discussion that why children are in this kind of a state. So there are, of course, these are theories. And these theories that I have picked up are from various studies, not from me. I usually, I said usually, I never invent things for myself. But here is what they say. For children, one is the cross-training. Cross-training is a term for innate arm. And what they say is that in the innate arm, so let's say this is the innate arm, and this is the acquired arm. In the innate arm, because children are exposed to respiratory infections more than the adults, and they take care of them more than adults, their macrophages and their dendritic cells and their neutrophils and their NK cells have have become more trained and aware of respiratory viruses and bacteria and can work with them better. So this is one reason. The second reason is that children actually exhibit less ACE2 in their, so the nasal area, although there are some studies that say, no, this is not correct. And there are some studies that say this is correct, and this picture is not that of a child. So sorry, this is a rather grown-up child like I am. So here, let's say this is nasal area and this is their oropharyngeal area. They have less density of ACE2 receptors. So that means that for the virus to get a hold of the cell and to enter, there are less ACE2 receptors. And the third phenomena is that children have, and this is a known thing, they have a greater number of natural killer cells compared to the NK cells in the adults. And I believe there are two reasons. One, children are brand new human beings and everything works well in them. So that is just one aspect. And the second aspect is we adults are more in stress, although children are under stress as well. They cry when they don't have food or they don't have a toy. But the kind of stresses that we go through are slightly different. And the result of that is a rigorous life, a stressful life causes the natural killer cells to be reduced in number. Children have a higher set of natural killer cells, which means that they can actually, at the innate arm, handle the infection very well. And because of that, they do develop their acquired arms function as well, but that function does not go too much. And they usually handle this asymptomatically. So that is a basic reason. There may be more, but these are the ones that have been repeated. Nina says we play outside all the time with children, and of course then they get the infections and their body is trained. And so the term is cross training, and that is that innate immune system does not have memory. But in cross training, the innate immune cells actually develop genetic expressions that allows them to respond better to respiratory infections. What does that mean? Just like we have developed, let's say, when somebody presses the bell button on our door, we have a very specific reaction to it, and we go to the door and whatever. So that is a learned behavior. In children, innate arm learns by having a gene set that is more frequently open to keep it open to combat respiratory infections, and that is how they can actually do better than adults. James Cook says, my wife and I had both Pfizer jabs. All good. Excellent. Congratulations. Very good. Coco Bean says, question, instructions by FLCCC to take ivermectin, lufimectin twice per month. You take it every week. Is there more protection with taking ivermectin every week? How long can someone take ivermectin? Very good question. And lufimectin. So here's the deal. There are some studies that say that ivermectin can sit in our body's tissues for a longer period of time, and the metabolites from the ivermectin, that means the breakdown products of the ivermectin, continue to appear in the fecal matter from the liver for many, many days. Although the dynamics of the ivermectin are that it takes a peak in our plasma at 4 to 6 hours, and then I have the board open so I can do this. So about 4 to 6 hours, it becomes peaked in our plasma. And then it becomes half of that in 18 hours, and then half of that in the next 18 hours, and so on. So that is its half-life. So the therapeutic window is usually this way, that it is, within the 18 hours, it can do its function. And the way it is given for worms is that it is given for some worms, once in a 3 months. For some worms, once in a 6 months, and for others, once in a year. So what is it that it is once in a year? Is it that the worm cannot come back into them in a year time, or is it that there is some level of persistence of ivermectin as well? This is something I do not know. I'm sure that there is data out there. So what happens is that FLCCC said, hey, twice. So bi-weekly, twice in a month, bi-weekly. And that data, that they have some reasoning for that. My reasoning is that because it goes down within 18 hours and it would cross below the therapeutic window very soon, so why not keep it within a week's time frame? So that means this decision is both, for both of them, for them and me, is more thinking what is the best in terms of its dynamics. Ideally, we should find out, as people use it now more often, to say what kind of concentration it develops in the tissues and how long. Now, second part of this question is that FLCCC also used The studies that were in India, Egypt, Malaysia, those studies had done, for example, Indian study did dose one on first day and then third day and then nothing for the whole month. Egyptian study had a similar pattern as well. So I think they kind of calibrated that to say, okay, you know what, bi-weekly. And I further calibrated it to say weekly. So far, my patients who have been taking it weekly, including my own self, we have had no issues. So that is the answer. India says, look, you show me hope. There is hope. That is what we've been doing for the whole year. We have been finding mechanisms, processes that give us hope. Plus, we have been educating ourselves to stay away from the fear mongering that these folks do, the media folks. Pasi, how are you doing? I see you after a few days. I hope you're doing good. Caroline, I like this Sunbeam. That's a good name. Okay, so question. So Asadullah says Ramadan cream to you as well. Here is a question from M. Gregory. Question, Dr. Bean, are you going to take lufimectin forever? So I am still taking it. And I am after dose one about 1 week now. So I am definitely not protected by the vaccine so far. But my hope is that I would continue as I move around. It gives me lots of confidence using ivermectin. So I would like to keep it. At least till the pandemic is over. Doug says a treatment for young children. So that is a very, very important question. And while I was having this, I was preparing for this lecture and pulling the data together. I was thinking that eventually the most important thing is that, fine, you found a child who has diarrhea from COVID, and you're a smart doctor. You heard Dr. Bean or read BBC or something, and you know that diarrhea could be. Now what? What do you do? So, Doug, before I open my mouth and just provide my thinking, which I'm not a pediatrician, I will do some research to talk about it. I'm very, very hesitant about maternal issues and children. So I would like to do some research before I speak. Colin Hummel says, is whooping cough derived from a coronavirus? I had it as a child 50 plus years ago and still remember it. That is so sad about the children, especially in Brazil. Yes, you're correct. Coronaviruses are not known to cause whooping cough. It is from other viruses too. And yes, Brazil and India as well. India is not doing good. I saw their numbers in the morning. They are not doing good. Sherwood is 14 says, question, should one take ivermectin in the morning with a meal, etc., for a long haul relief? So I have been taking ivermectin in the evening with my meal. So I think it really, with meal, is important so that it is absorbed more instead of staying in the gut. But the time can be of your choice. Somehow I don't see Margaret today. So Stephen, we haven't seen France for some time as well. Oh, sorry, not France, Japan. I saw France a few in the last. France is here. Nina, I'm thinking once we have pills that give mucosal IgA, we'll end this. So France is here. I meant Japan. Stephen Westman says, AstraZeneca and JJ vaccine, for how long after injection should patients be on guard for the very rare clotting reaction that is thought to be dangerous? So one, I think almost all of you would have seen that there was a Oxford message that, hey, we have a study that shows that it is not just the AstraZeneca, it is also Moderna, Pfizer, and COVID-19 causes even more clotting. So I still believe that, fine, even if it is all the vaccines, I still believe that after the news has become digested, the second part is to say what to do about it. Instead of saying, hey, this, it happens with others too. So then there is no solution. The solution, the video I did a couple of days ago, that is a solution. And these authorities can come up with a solution. I'm a small voice. So, anyways, let's see. What did we have? The AstraZeneca and JJ vaccine after injection. So, what happens is that, so imagine that the vaccine arrived in our body and it is picked up. Hey, Luffy, it is picked up by some cells. Once it is picked up, it will be presented on the cell surface. Correct? Now, this can take a few days. And I would give you a window. So let's give the window first. It can be anywhere from 5 days to 7 days, 17 days. Sorry, seven, I said. That is a window. So what happens is, now that the innate arm is presenting the vaccine, then the adaptive arm, the T helper cells would come in and they would attach. So that is a naive T cell. Then we know T helper 2 pathway can occur, T helper 1 pathway can occur. There can be a percentage of both. The plasma cells would be formed. These plasma cells and the cytotoxic T cells, they will make the antibodies. These antibodies can be made anywhere from 5 days to 17 days. In some people, even 29 days. But this is the prevalent time. This is the most people's time. That within this time frame, they will have antibodies. And the mean time, that is more than 50% of the people, develop those antibodies within 9 days. So 5 days to 17 days is the window to stay vigilant. 9 day, up to 9 day, or the ninth day is the most common or the mean. So for example, my wife, ninth day, I think was yesterday. So we are beyond it. She's still not out of this risk, but this is the most common window. And let's say if it is with Moderna as well and with J&J, Pfizer as well. So I have Moderna. I am yet at fifth, sixth day. So I am just entering the window where there may be antibodies being produced now, and their production can then cause this issue if this can happen. So I hope that answers that question. Kevin says, why is the virus surging in certain countries? So think about it. India was actually doing very well. They were locking down. They were taking care of it. Doctors had learned how to handle this. And then a couple of things happened. I believe one, the variants arrived that had a faster, rapid way of spreading. And secondly, some of these events arrived, the elections, the Kumbh Mela, the Holi. And I think there is a third factor as well, and that is people felt that, hey, we are done. The infection rate had gone down for a big population to say, hey, we don't have any cases, our cases are 1,000 a day or so. That was a big change in the scare. So I think people became a little relaxed as well. So result of that was that we have now these cases. So that's a different phenomena maybe than what is happening in Brazil. So it's not necessary maybe that in Brazil everybody has become careless, but maybe there is something else. Maybe the ivermectin stoppage by the Brazil's president, maybe the no lockdown, maybe there is no social distancing, there is no masking. So there can be various factors. But I want to make sure that saying that somehow vaccines are causing acceleration of infection is wrong. There is no such data and there is no such mechanism. Seasonality. So Pasi says seasonality. Pasi, I think that in the beginning, this virus didn't have seasonality. And the reason is very simple. We were all a fair game for it, and it was able to enter our bodies and infect us. So it didn't care for the season. It was just going from one person to the other. Once we have developed immunity to it, either by becoming infected or by becoming vaccinated, then it would have to now reside in some of us and become active whenever it can. That may be activity with the cold, or that may be activity with when their immune system is compromised for some reason. Let's say we have become sick and our immune system is busy in something else, or nutrition status, or diabetes, and so on. The interesting thing is this virus can actually replicate at warmer temperatures. Other coronaviruses that are seasonal do not replicate at warmer temperatures. They can only divide and increase in number in cold temperatures. And that is why in winters they get the chance to increase in numbers. This virus is so brutal that it can actually continue to replicate in deeper tissues which are warmer, and it still can continue to go. So season is less of a problem for it. The season can have one more effect, and that is transmission. And that is not the virus itself, that is the moisture in the air, the temperature of the air, and how much can it travel, and how long can it travel. So these would be the aspects of seasonality. So Hugo says, what's your gut feeling, lab mate? So in my whole 1 year, I have said that once, that I feel that there is too much of a change in this virus, that it seems like something had someone, it was intervened with. And I got a lot of heat for that, where is the proof? And I don't have any proof. So because of that, saying this is kind of not right for me. But this virus has a lot of functions that are very, very different. Rajesh says in India there's a scramble for remdesivir injection, and that is, remdesivir would help whatever it can. I think at the end of the day, ivermectins, vitamins, hydroxy with zinc, or quercetin with zinc, with azithromycin or doxycycline, with steroids starting within 2-3 days of the infection, or inhaler started with that, would be more beneficial compared to remdesivirs or dexa. But these have to come in, but at more dramatic time when the intensity is high. Arun says Indian servo survey discovered that antibodies are present for 6 months and vanished, so there is severe second wave. No. So this antibodies vanishing is not a proof that immunity is gone. I have said it many times that our cells, B cells and T cells, once they become active, so let's say I become infected today and the cells become active. Within a few days, 5 to 17 days, they'll become active and they would start making antibodies and they start doing cytotoxic activities, and the immune system is active. It would take care of the virus, hopefully, and the virus would go away and I would survive. Then the cells would sit around and say, okay, I'm making more antibodies, but I don't see any more antigen here. I'm not tickled by the antigen, but I'm making antibodies. Fine, I'll continue to make it for 1 more month or 2 more months or 1 more week. And then, you know what? I still don't see any antigen. I'm just going to kill myself. So those active cells would cause apoptosis and they would degenerate and they would go away. Some of the cells, right in the beginning, when the proliferation of the cells was occurring, when the number was increasing, some of the cells will become memory cells. They would stay there. So even if we don't have antibodies after 6 months, ideally we have memory B cells or memory T cells or both. And when I say memory T cells, I see many doctors, including our friend Dr. Z-Dog MD, making this mistake. Look, they say that somehow B cells may not be present, but the T cells will be present. And that's a very weird way to look at it, because here is the thing. This is the innate arm. Let's say this is a macrophage or a dendritic cell. It is going to help a naive T cell to become activated, correct? So this is a naive T cell. It doesn't know the purpose of its life. It just is there. Naive T cell would then be converted into T helper 2 or T helper 1, correct? So tell me this, the T helper 2 then releases interleukin 4 and 5, and that causes the B cell activation. And similarly, T helper 1 would then release interleukin 2, and that would cause cytotoxic T cell. How can we say that we would have cytotoxic T cells, we would have these helper cells and their memory, but we will not have B cell memory? That just is not even possible. That is like saying I'll climb up the stairs, but I would not go upwards. Maybe there are some stairs which are climb up but are down. So here we have the innate arm moving in this direction, and first interaction is going to be T helper. So we will have T helper memory, but having T helper's memory means we would have cytotoxic and B cells. Their percentages can be different. We may have 90% B cell and 10% T cell, or the other way around, or a different percentage. That is possible. But having helper T cell as memory means the next step is done as well. So when we have antibodies, so let's say these B cells have decided that, hey, you know what, we have done enough work and we are not tickled by the antigen anymore, so we're going to either die, or some of us who are the memory cell are just going to go sleep somewhere. So they're sleeping. And then when you actually send the virus again, that virus comes in and says, hello, I'm here. And as soon as that happens, that would wake them up and they would start working and they would start producing antibodies. This is why production of antibody, presence of antibody is not that important as much as the production of antibody when we are challenged. And that is why the T cell test is very important, because if the T cell test shows T cell present memory, then that we can assume that memory B cells will be present as well. So if you have a question, please put, so here, some cues in the question. I said put question in front of your question so Dr. Bean can spot them easier. Yeah, so if there is a question, just put cues there. William says, I should just give up and buy a paper for me and my two kids. Why, William? I hope you're doing okay. Kevin Brazda says, question, Dr. Bean, is there a risk that's notable for clotting with mRNA vaccines? So I have to actually look at the data. So I saw this this study this morning, I think 2 hours into it, that media started doing their media thing. The song of their people, they started singing. And I then went to the original study, and the study said that what we have observed is that the percentage of Moderna clotting by Moderna is, I believe, 4 in a million, and by AstraZeneca is 5 in a million, and then by COVID is 19 in a million or something more crazy. So I think their point was, number one, others have it too, and the second is, hey, it is still better than the COVID. So I agree that it is still better than the COVID. I don't think this was the right way of saying it. So I have known this much. I haven't yet looked at the data to be able to make an opinion that yes, Moderna and Pfizer are also in the similar ballpark. My only curiosity is, if Moderna and Pfizer were doing this as well, and we have given tons of doses over here, if we could stop with Johnson & Johnson with 6 cases, and one died and one is in ICU, and with that we said, you know what, let's stop. Are we that bad that Moderna and Pfizer kept going for 80 million doses, and this happened at a very large scale, and we either didn't know or we just ignored it? That is my curiosity after seeing the study this morning. So I have to do some research. Jimmy Lowe says, if a person is fully vaccinated, will they have better chance of mounting an antibody defense against variants that escape the S protein? Thank you. Yes. And very, very interesting question and important questions. And Bonk Bonk is saying interferon for long COVID. Yes, interferon. I have seen the comments here by some folks who said my long COVID was not resolved by anything. And when I got interferon, it magically disappeared. So I think we have to put that video together with all of these anecdotes. So the question was from Jimmy Lowe, if a person is fully vaccinated. So yeah, let's see. Let's say vaccine. So your question is fully vaccinated and then is against variants to escape the S protein. Okay. So let's say vaccine. And let's say the vaccine is making, I'm going to intentionally make this weird shape so we can talk about it. Let's say this is the spike protein shape that the vaccine developed through its genetic material, RNA. And our body, in turn, created, let's say, an antibody for here, another antibody. It would actually make tons of antibodies, but I'm just intentionally creating a scenario where we can say there is an escape that occurred. So these are some antibodies that are produced. Then comes a variant. Now let's see the variation intensity. Let's say we have a spectrum of variation. And so we say from minimum to maximum variation. So now on the minimum side, we say, you know what, the new spike protein that is with the new virus, the variant, is something like this. It is, I'm now going to try to make similar thing, and then I would just make it this way. So this part I've removed here. And so now what happens is that these antibodies are fine, these are fine, this is fine, but this one is scratching its head saying, where can I bind? And now it cannot bind anywhere because this part has changed. And now we have less efficacy of this vaccine generated antibodies. Now the question to be asked will be, will this be sufficient for the virus to become more infectious or stay infectious with this variation and beat these antibodies? And so far there has not been any virus that has come up with enough variation. We are fortunate that coronavirus have proofreaders in it. Coronavirus mutations are very difficult, very slow, because its own proofreader keeps correcting the changes. I should not say this because somebody in some lab is going to listen to that and try. If the proofreader is modified, for example, to not proofread the spike protein, if you just eliminate the proofreader, then the virus cannot survive. It would just die. It would create so many mutations so fast that it would just be disabled. So proofreader has to be smart enough to say, you know what, I'm not going to proofread the spike protein, but I'm going to proofread the rest of the things. If that happens, then the virus can change the spike protein so fast and so much that it can start evading. But then the question would be, will that change be sufficient for it to still continue to bind with ACE2? It has to stay functional as well. If my hand changes, if it does not work like a hand anymore, then I'm disabled. So that is one. Then let's say somewhere in the middle of the spectrum, there is another change, which is, let's say, like this. And now one more antibody has become defeated. And now these two. And please remember the spike protein, I have done this discussion in detail in the past, that there are hundreds of epitopes on the spike protein, and there are hundreds of possible antibodies that would be formed. I am just using an example of 2, 3 so that I just don't have to draw too much. So now let's say there are 2 and 2 are defeated. Then this efficacy has dropped even more. And the same message again for this as well. And finally, let's say here, this virus has somehow figured out enough mutation that it can still bind with the ACE2 receptor, because eventually this spike protein has a function to perform, and that function is to bind with the ACE2 receptor. So imagine that somehow it has kept in mind how to bind there, but everything else has changed. That is like saying that the hand is changed, into a foot, but hand is still working as a hand. That would be really difficult. But let's say that happens. So now what has happened is that the receptor binding domain or the binding area is still fine. All else is changed. And then all antibodies somehow were not targeted to domain at all. And they were just targeted to other pieces. And now they cannot work with it. And now they're defeated, all of them. Reaching this will be a very difficult situation for the virus. And then keeping itself functional as well, that it needs to work with ACE2. So that is the problem that this virus has to fix. I think this virus would not try to escape with the immune system. Instead, it's going to learn to live with us and be less damaging to us so that we do not trigger a lot of immune response, just like other viruses have learned to live with us. I think that would be more possible. But to answer your question, this is the mechanism. John Riaz says, Doctor, do you have a ballpark guess of how many US hospitals are now using iMask Plus as a percentage? So I think there were doctors who were using it. And I believe that with the WHO's message, even those doctors would have been thinking. I actually should call some of them and ask them that how are they feeling, what are they doing. But I think that hospitals in general would just step away, and the doctors who are doing it, even they will be worried, which is a great disservice that WHO has done. And WHO is not a box, there are people in it, and this is a disservice done by people to people. That is the, I can't even imagine how. But anyways, I'm sure that they are sitting somewhere saying, we are good, we made a very good decision, these guys are crazy and talking about this. So I'm sure they're justifying their action, but weird action. Jim, I've seen you after a long time. I believe I got a bug from Mike. I haven't eaten since Sunday. I tested negative for COVID Sunday. So today is Thursday. I'm still waiting for lab work on a stool sample. No diarrhea, loss of taste yet. No vaccine yet. So, Jim, number one, hope you feel better soon. The question is no vaccine yet, meaning the question is that should you take a vaccine or not? So I just didn't get the question part of it. The symptoms that you're saying, they don't seem like COVID, but as I have always said, that in pandemic you always start with this may be COVID and then you figure out if it is not. But can you please elaborate the question? My apologies, I couldn't get it. And Scanlan says, question, why no incidence of clotting in other traditional adenovirus vaccines? What is unique about COVID vaccine? No, so this is why, and actually, you know what, I should show this. If you give me just one quick second, I'm going to search for brief from, what is their name? Johnson & Johnson. So please don't mind me taking your time, but this is important because some folks on Twitter were asking me as well. So FDA, I believe the Johnson & Johnson is here. I believe this is their brief. So one second. So I'm trying to open this here. I believe this is their brief to FDA. Let me just confirm it. Yeah, vaccine related biological product advisory committee meeting, FDA briefing documents. If I search here and say concern, sorry, I know that here. So read this, and anyone else who was asking me And I know that they were not asking me to challenge me that I'm telling something not true. They were just asking for a reference. So if you see here, this is their FDA document. Janssen submitted a pharmacovigilance plan. So there is a plan that, hey, we are going to look for some things that we know may happen to monitor safety concerns that could be associated with Janssen COVID-19 vaccine. The sponsor, that is Janssen, identified vaccine associated enhanced disease, including vaccine associated enhanced respiratory disease. So they said it is possible that ADE might occur, and that ADE may be for the lungs. Anaphylactic reactions might occur, and thromboembolic events as important potential risk. They don't say clotting, and we probably search for clotting and then we can't find it. Thromboembolic event is the medical term for this. Why are they saying this in their FDA brief? They're saying this because adenovirus based vaccines are known to be associated. I'm deliberately not using the word cause, because then folks start hammering me that why did you say cause, and show us where does it say cause. So I have to use the same medical jargon and say it is associated with, it is related with, it is linked the to this. So this vaccine, adenovirus based vaccines, are known to be linked with clotting. That means Johnson and Johnson. That means AstraZeneca. That means Sputnik. That means what is that, CanSino or something, which is also adenovirus based. So this is this platform's problem. So I hope that answers that question. Uh, Nitin Agarwal says China, UAE, and others are using inactivated vaccine and seem much better and seen much better results. Why others are not following? And I think we should. I actually believe in it. That so I'll tell you my own progress on the foreign vaccines. My irritation was that they do not have data. And I had become so used to looking at these FDA briefs and the full data, and then even hammering these big companies to say, you guys suck, you guys are bad, and show us more data and tell us more. And then here is some vaccine from China, for example, and there is no data. And the company's CEO comes in and says, I think this does this and this and this, or UAE said this does this, and we live with that. However, China's vaccine, I do not know about Sputnik. China's vaccine, Sinopharm, has been used by a number of my friends to administer to their patients and to my family members. And I have seen no side effects, at least the people that I know. That's not a study. It's just anecdotal, an observation like a common person, I'm telling you, not as a doctor, that I saw no side effects. And when someone's wife became ill with COVID, he only had 10 hours of malaise, and that's it, and became okay, and nothing else. So I think, Nitin, that there is something to be said about inactivated vaccines. India has an inactivated vaccine as well, and they should be looked at. Ni Hui says it was the reason to stop whole inactivated coronavirus, ADE. I have talked about this many times that ADE is not, it is so interesting, medical field and the scientists. So check this out. There are scientists who say that because you're creating antibodies only against the spike protein, the mutations in the spike protein would make these antibodies useless, and the remaining virus is still active, and we do not know what to do with that, and so the hell would break loose, and we will die because the variants would just beat the spike protein antibodies. Then there are folks who say, you know what, the whole inactivated virus is awesome, but it creates so many antibodies that we would get ADE. There is even one more theory that it would create so many antibodies that they would collectively be weak. So there is no data or evidence of saying that the inactivated virus created ADE or caused ADE, or the spike protein viruses have become fully defeated, the vaccines have become fully defeated. On the spike protein, our focus is more, so we actually on incrementally every day know more. There is one more mutation, there is one more mutation, there's a double mutation, and now there's going to be some change. So we are hyper focused there. We are less focused on the inactivated ones. But the point of discussing this is that both type of vaccines have their critics, and the people now are scratching their head that this doctor says this and the other doctor says this, and they both are doctors. So data has to justify the record and clarify the situation, not the doctors. And that I know includes me as well. But data would have to tell the thing. And I don't think that these mechanisms are causing the acceleration. Philippines stopped ivermectin. Turkey has their own issues. Brazil has their own issue. We are looking at that. India is now accelerating. You can't say that on the vaccine. So let me add one more layer to this discussion, and that is, if you go and check, let's say, Bloomberg, and you check for India's vaccination. Luffy's here. So India's vaccination, if I go down here, show more. When I am in front of camera, I become blind and sometimes I can't find things. So let me do this. India. Here, it was the third from the top. So look at this. Fully vaccinated 1.1%. One dose 7.5%. That is not sufficient. Similarly, look at Turkey. Fully vaccinated 9.3%. And one dose 14.4%. This number of vaccination has nothing until they reach 50% or above. There is actually a very interesting statement here by Bloomberg that I was reading it out to the morning folks. COVID rates have flattened or declined in the 4 places where enough vaccines have been given to cover at least 40% of the population. And so we give, let's say, 5% or 4% and then start saying that, hey, somehow the vaccine is to be blamed. No, it is just the vaccine has not gotten enough coverage. Or if I say it in a different way, even the herd immunity from original infection is not to be blamed, because that also has not covered enough population to create protection. MJ says, I am on Brilinta. This should become a separate video. Will that protect me from the clotting issue? That's not rotational blood thinner. So I can only talk about the traditional blood thinners. I will have to see the mechanism of action for this one, Brilinta. I have found this about myself, that when I'm in front of the camera and I'm talking, my brain just becomes very locked down. Lisa says, a vaccine for children now, or better to wait until big pharma gets their act together, meaning waiting for non-emergency vaccines. You know this, I've said this, Lisa, once before as well, or Liza, that I'm not super excited about this vaccine to children yet. And that is just maybe I'm very sensitive towards children. But maybe the answer is to vaccinate them as well. So difficult question for me to answer. I would take your second option in there to say, let's wait for the vaccine to be given to some more people and they figure out what are the issues with it and they acknowledge them, recognize them, fix them. Then we move towards children. But they're not going to listen to me. They're already doing trials on children. Colin Hamill says, if we got our own country's health advisory boards nervous about following WHO guidelines on ivermectin, would they then turn on the WHO to shift liability? It is possible. Look, WHO, in my opinion, has a severe lack of leadership. And I'm not hitting on anyone that a person being leader. Lack of leadership, that is decisions coming from them which are educated and informed. They are right now being pulled by the nose by various folks who can show them studies or partial data and say, look, and they say, yes, you're right. And Sergi Safir is a very important example that they actually convinced WHO to say, stop hydroxychloroquine things. Then WHO stepped back, but they had done the damage. And such a big organization with such a responsible position, making such childish mistakes simply means they do not have any process working inside. They are just, I think, bureaucrats sitting somewhere and doing favors and talking and saying, okay, yeah, you brought this study to me, it looks good, okay, make a decision according to that. And they are not asking to be to challenge those studies or to verify what is happening. So I think that is the problem. Now, if the local authorities do become nervous, they would say, yeah, sure, we're going to break loose from WHO and make our own decisions. India did that, I think, not out of nervousness that they were afraid of someone. They wanted to protect their people and they wanted to not have this explosive thing, which unfortunately we are seeing at this time. And they used hydroxy, and WHO said no, and they said no, we think we should continue, and they use ivermectin as well. So I think that is the proper way to make a decision, to take responsibility and make a decision. Our authorities, local authorities, they don't want to have the responsibility of a decision, and that's why they're not making them. Asadullah. So let's see. So Pasi says, Asadullah, did I say if you get no answer, haha, grumpy. So let's see. Pasi, sorry, I'll find Asadullah's question and answer. Asadullah says, Pasi, did I ask you? Oh, Asadullah, we are all a community. You are part of this. We just chit chat and talk. We all have a very good understanding of this for after a year. But Asadullah, Dr. Bean, does the vaccine affects fertility? Our doctor told us not to take because it can cause infertility. Explain this. So no, we have done this discussion many times. For the vaccine to cause fertility, it has to either change our hormones or change our, for example, for a man, change their testicular tissue enough to actually damage the Sertoli cells, which are the parent cells to make sperms. Sertoli cells have to be destroyed. These are the stem cells that have to just go away, and vaccine cannot do that. In a woman, one, it has to either disrupt the hormones, or it has to destroy the ovaries, or it has to do something to the fallopian tubes and all those pathways, or it has to do something to the endometrium to destroy the endometrium. Vaccine can't do those things. It is not built to do those things. So if it was so easy to make a vaccine that can make somebody infertile, then those folks who wanted to have contraception, and there are folks who want to have a permanent contraception, they would just take a vaccine and they're done. And they would not be waiting around for all the extra things. So this, when a doctor says that don't take it because it can make somebody infertile, I don't know what doctor is doing. But no, it does not cause infertility. Alind Botti says, which vaccine has less side effects, AstraZeneca or Pfizer? So I did a video about a week ago. The video's title is Comparing Three Vaccines. Can you please check that out? Actually, you cannot, and I was struggling with this question at that time to say, can I come out and say Moderna is the best, or Pfizer is the best, or J&J, or Astra? And it turned out they all have some kind of side effect that you would listen to and say, man, I don't want to have that. So they all have their own issues, and you should see them. You can either read the FDA briefs, or you can watch my video where I have shared some of the side effects that I thought important. The best is to look at the FDA briefs as well. But any one vaccine to say, for if you ask me for my preference, I have become reserved about adenovirus based vaccines. So Pfizer is not adenovirus, AstraZeneca is adenovirus. So I'll probably protect myself from AstraZeneca and move toward Pfizer, but that is just me as a human being, and with all of this data and the discussions that we are having, making that decision. William says, I'm literally ordering fluvoxamine just for antidepressant purposes now. Fluvoxamine is good, just be, we talked about it, William. I hope that you recover soon and you're safe. Gems, international travel is not stopped. Okay, so let's answer a couple of more questions and then we stop. Ali Jaffrey says, ivermectin prophylaxis in fully vaccinated person. Fully vaccinated person, prophylaxis for variants. Yes, so should be, if you are a believer of ivermectin, then yes, I am continuing even after taking my vaccine, although I'm not fully vaccinated yet. So yes, I think instead of my weekly prophylaxis, maybe bi-weekly prophylaxis may be okay, but I would prefer. George says nucleocapsid is considered less mutating prone and so considered a possible target for a vaccine. How the antibodies could neutralize virus if nucleocapsid is not exposed in the virus like spike does? Very good question. And here is the deal. Very important question. I wish I have a little more time to discuss this. I wanted someone to ask this question, so thank you. Here is the deal. We have somehow started to think that when we have a virus, and then we have, let's say, the spike proteins here, and spike proteins bind with ACE2, right? We have somehow started figuring out that it is just the spike protein that we have to bind with, and that is the only way to stop a virus, that we have to somehow attach to the spike protein. Actually, our body doesn't even care for these kind of things. It would make antibodies that are going to go get stuck with the virus. When the antibodies become stuck to the virus, they would activate complement. Complement activation would cause some proteins on the surface of this silly virus to start breaking and start making holes in it. Plus, they would coat this virus with these breakdown products of the complement, which make this virus very yummy for the macrophages, and for example, C3b. So macrophage comes around and says, oh my God, look at this. There is a beautiful, beautiful C3b here, and I want to eat it. And it has a sweet tooth for C3b, and it would actually eat this thing and destroy it. Similarly, C3b and other activating parts of the complement would cause the other cells, they would cause chemotaxis, and other cells would rush to that area, and they would be just fight, and they would destroy this cell, this virus. This is what happens when the actual virus comes into our body. We don't know how to neutralize the virus. We just attack it everywhere. We stab it in its tummy, and we stab it in its chest, and we stab it in its arms. We just take care of all of it. So this has become a very strange feeling. And I think it's not people's fault. I think it is media and the scientists, vaccine makers, who tuned us to this, that, hey, we are making something really awesome for you, and that is neutralizing antibody. And now you are covered, and somehow that has produced another side effect in our thinking, and that is that if we are not neutralizing, then we cannot take care of the virus. We will take care of the virus in a very easy way if we have the antibodies. We can even take care of it if we don't have the antibodies, and we can make them and destroy it. So, good question. I answered it quickly, but I hope that that answers your question. So, how about we stop for now today, and we continue tomorrow? Um, so do me a favor, please like, subscribe, and share. And there is a super chat as well. So thank you very much for the super chat. So that is William here. Thank you for asking about me. My intestinal issue, SIBO, is what my doctor said is 98% resolved. I've been treating with oil of oregano to kill the bad bacteria, waiting hours, and you awesome. So I love to hear that you're improving. Thank you very much. And thank you for the super chat. And thank you very much, everyone, for being here. Please like, subscribe, and share. And there are 3 links in the description. One is if you don't want to use the PayPal and want to support this work, you can buy me coffees. Another one is to become a patron. And one link is to support this work in general. Thank you very much. And I would see you tomorrow morning. Actually, tomorrow is 16. I have to go for my car's service. So tomorrow morning, I'll be absent. So I'll see you tomorrow evening. Bye-bye.